Welcome to this pediatric asthma review on multiple choice question strategy. Asthma is one of the most heavily tested pediatric topics, and the good news is that the questions follow a predictable pattern. In the next several minutes, we will not reteach every detail of asthma. Instead, we will show you how to read these vignettes, how to classify the patient, and how to pick the next best step the way the exam wants. Pair this with your question bank and a trusted pediatrics review resource for the underlying content, and use this video to sharpen how you apply it under pressure on exam day. Here is what we are going to cover today. First, we will classify asthma severity and control, and match the patient to the right controller medication. Second, we will treat an acute exacerbation in the correct order, and review how to coach proper spacer and inhaler technique. Third, we will build an asthma action plan that a family can actually follow at home. Throughout, the focus is test taking. We will work through high-yield question stems and walk through full answer explanations so you can see exactly why one choice is right and the others are wrong. Keep your question bank and a solid review resource handy because this video is about strategy, not memorization. Our first strategy is to classify before you treat. The exam almost never lets you pick a medication until you have decided how severe the asthma is. So start with the last line of the question, which usually asks for the next best step in management. Then go back into the stem and hunt for the numbers that matter. How many days a week does the child have symptoms? How often do they wake at night? How often do they reach for the rescue inhaler? And how much are normal activities limited? Those frequencies tell you whether the patient is intermittent, mild persistent, moderate persistent, or severe persistent. Find that classification first, and the medication choice almost picks itself. The classification is the hidden question inside the question. Strategy 2 is to step up and step down by control. When a child needs the rescue inhaler more than twice a week, wakes at night, or keeps having flares, that child is not controlled on quick relief alone. The exam wants you to add a daily controller, and the preferred first controller for persistent asthma is a low-dose inhaled corticosteroid. Watch out for answers that only treat the symptom in the moment. Now, if a patient is already on a controller and still symptomatic, do not jump straight to a powerful oral medication. First confirm that the inhaler technique is correct and that the family is actually using it, then step up the dose. And when a child has been very well controlled for several months, the exam may reward stepping down therapy instead of leaving them overtreated. Strategy 3 separates quick relief from daily control, and it warns you about the overkill trap. Every asthma question hides 2 buckets of medication. Quick relief is the short-acting bronchodilator used during symptoms. Daily control is the inhaled corticosteroid that prevents them. When the stem describes ongoing symptoms between visits, the right answer is almost always a controller, not another rescue inhaler. Match the strength of the treatment to the severity you classified. An intermittent patient needs only a rescue inhaler. A persistent patient needs a daily inhaled corticosteroid. And beware the impressive sounding choice, like a daily oral steroid or a specialist referral for a stable child. It feels thorough, but overtreating a well-controlled child is wrong just as often as undertreating. Choose proportionate, guideline-based care. Let us work through our first practice question, and this one is all about classification. A 7-year-old boy comes in for asthma follow-up. Over the past month, he has had daytime cough and wheeze about 4 days a week, and he wakes from sleep with symptoms about twice a month. He uses his rescue inhaler on those symptom days, and right now he takes no daily medication. His exam today is normal. The question asks for the most appropriate next step in management. Take a moment to classify him in your head before you look at the choices. The options are to continue the rescue inhaler alone, to start a daily low-dose inhaled corticosteroid, to start a daily oral corticosteroid, or to refer to a pulmonary specialist. Decide on your answer before we break it down. Let us break this down step by step. Step 1, spot the pattern. Daytime symptoms several days a week, but not every single day, plus a couple of nighttime awakenings in a month, is the classic picture of mild persistent asthma. The key word is persistent. Once the symptoms cross beyond the intermittent threshold, a rescue inhaler by itself is no longer enough. Step 2. Apply the rule. Persistent asthma calls for a daily controller, and the preferred first controller is a low-dose inhaled corticosteroid, so that is our answer. Step 3. Eliminate the wrong choices. Continuing the rescue inhaler alone undertreats persistent disease. A daily oral corticosteroid is the overkill trap. Far too aggressive here, and referral is premature for a straightforward classification you can handle yourself. The answer is to start a daily low-dose inhaled corticosteroid. Here is our second practice question, and this one shifts to an acute flare. A 9-year-old girl comes to the emergency department with 2 days of worsening cough and wheeze after a cold. She is speaking in only short phrases. She is breathing fast, and she has audible wheezing with mild chest retractions. Her oxygen saturation is 91% on room air. The question asks for the most appropriate first step in management. Notice how different this stem feels from the last one. This child is unstable right now. Your choices are to obtain a chest radiograph before any treatment, to give supplemental oxygen and an inhaled short-acting bronchodilator, to start a daily inhaled corticosteroid and send her home, or to give intravenous antibiotics for presumed pneumonia. Pick your answer before we walk through it. Let us work through this answer. First, treat first and image later. The low oxygen, the fast breathing, the retractions, and the short phrases all tell you this is an acute exacerbation, and the airway needs help now. The setting is the emergency department, and that setting is a clue that the right answer is active treatment, not a workup. So why does quick relief come first? Supplemental oxygen plus an inhaled short-acting bronchodilator is the correct opening move, with systemic steroids following close behind. A chest radiograph just delays care and does not change what you do next. A daily controller does nothing for the flare happening in front of you, and antibiotics treat a diagnosis the stem never actually supports. The answer is supplemental oxygen and an inhaled short-acting bronchodilator. Let us talk about spacer and inhaler technique, because the exam tests it in a sneaky way. When a child is still symptomatic, despite a reasonable controller, the tempting move is to raise the dose. But very often the better answer is to check and correct the inhaler technique first, because poor technique mimics treatment failure. Remember that a young child should use a metered dose inhaler with a spacer, and the youngest children, who cannot seal their lips around the mouthpiece, add a face mask. Here are the high-yield steps to coach. Shake the inhaler, attach the spacer, press once, and have the child breathe slowly several times from the spacer. And always have them rinse the mouth after an inhaled corticosteroid to prevent oral thrush. If a question offers checking and correcting technique, that is frequently the next best step before you change any medication. Here is our third practice question, and it rewards thinking about the whole family. A 10-year-old boy with mild persistent asthma is well controlled on a daily low-dose inhaled corticosteroid. At a routine visit, his mother asks what the family should do at home when his symptoms start to flare. He has had 2 flares this year, both triggered by colds. He feels well today and his exam is normal. The question asks for the most appropriate next step in management. Your choices are to provide a written asthma action plan with green, yellow, and red zones, to stop the inhaled corticosteroid since he feels well today, to start a daily oral corticosteroid to prevent flares, or to tell the family to return to the clinic for every symptom. Choose your answer before we go through it. Let us break down this answer. First, think about what the family actually needs. A controlled child whose mother is asking how to handle flares at home needs a written asthma action plan. That plan uses a green zone for normal days, a yellow zone for early symptoms with clear rescue inhaler steps, and a red zone for danger signs that mean get help now. Handing over that plan is patient-centered care that supports the whole family, so that is our answer. Now the key distinction. Stopping the controller in a child who is only well because of it just invites another flare. A daily oral corticosteroid is the overkill trap for mild persistent disease. And telling the family to come in for every symptom ignores the self-management the plan is designed to provide. Each wrong choice either does too much or too little. The answer is the written asthma action plan. Here is a critical exam day pearl that ties all of these questions together. Classify, then choose. On every asthma question, classify the patient before you even look hard at the answers. Decide whether the child is intermittent or persistent, and decide whether their current regimen is actually controlling them. Doing this first turns a confusing vignette into a simple lookup, and it protects you from being lured toward the most aggressive choice. Then match the management step to that classification. Intermittent disease needs only quick relief. Persistent disease needs a daily inhaled corticosteroid. An acute flare needs oxygen and a bronchodilator. And a worried family needs an action plan. When 2 answers both look reasonable, choose the one that fits the guideline step for the patient sitting in front of you. That wraps up our review of multiple choice question strategy for pediatric asthma. Keep drilling these patterns in your question bank until classifying the patient and choosing the right step feels automatic, and read every explanation, even for the questions you get right. Practice under timed conditions so that classification, controller choice, technique, and action plans all feel natural on test day. If you want more help, visit roadmaptoresidency.com, where our expert tutors and residency advisors can help you build a personalized study plan. And if this video helped you, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.